there's a profit incentive, no question. And maybe it's their confidence in themselves too. Oh, I have a 75% success rate, whereas the national average is only 50. But they may select their patients too. So I couldn't answer that directly. I know how we are at UAB and at our VA.
I have a friend who the doctor operated on her shoulder 6 months later. He wants to operate again on the same shoulder.
Probably not a good idea. Okay. Yeah, shoulder surgery also has a high failure rate. Okay. Lots of murmurings going on in the room. PT, okay, physical therapy. We're going to talk about other modalities, okay? So we talked a little bit about chronic pain. There's an onset of pain, and then the inflammation, scarring, and remodeling. After 3 to 6 months, everything should sort of stabilize. But if the pain persists up here, it's coming from something else. Neuromas, scarring at the area, whether it's in the shoulder. Things like atmospheric changes. Oh, my rheumatism's acting up because it's going to rain, kind of thing. So again, in veterans, things that can sort of fuel this cycle of chronic pain, things such as anxiety and fear, disability, PTSD. All these factors influence the perception of pain, and when you give an opioid, it really kind of addresses the pain. It may decrease anxiety a little bit. Okay, actually, there's older data that shows that morphine and opioids are. In fact, we used to give when somebody had a myocardial infarction and they were just like this because their epinephrine was up really high. We'd give them morphine in the emergency room and an intensive care unit, and that lowered their anxiety. So we mentioned that with anxiety, arousal, you get increased pain perception, re-experiencing some traumatic event. That's a very potent reminder. And we know that we have a lot more power over pain. I'm sort of reminded of, the Indian guru who walks on the hot coals and doesn't seem to be fazed. I don't know how they do that, but they know, okay? I guess he's the Bhagwan, or the guru that everybody goes to to ask him about problems. I'm reminded in the movie Lawrence of Arabia, when T.D. Lawrence, there's a candle, and he reaches over and he just kind of puts the candle flame out with his fingers. And one of his colleagues said, "Didn't that hurt?" And he said, "Of course it hurt. You just have to not mind that it hurts." Okay, so he's sort of making a point that it's really about mind over matter. Now, pain is real, there's no question, but learning to manage pain, sleep is a great manager of pain. When you go to sleep, you don't feel the pain. Okay? So the brain is basically the pain is being shut out because of our awareness. Your state of awareness has changed. So again, the traditional biomedical model of pain care is that you can treat it with a pill, you can operate on it or cut it off. Okay. Well, we know that if you amputate a limb, you can have what's called phantom limb pain. I had a guy just in clinic just 2 days ago at an amputation. He says, "It feels like my foot is on fire." He had diabetic neuropathy. And he's in more pain now than when his neuropathy was present. And that's probably signals from the nerve that's been severed. It's still sending a signal back to the brain saying, your foot you need to do something here. Okay. Again, we talked a little bit about expenditures being linked to chronic pain. in the last 10 years, epidural injections up 600%, opioid expenditures 400+%, MRIs. We don't have any problem getting MRIs at the VA. In fact, I like to get MRIs because I can show my patient, yeah, you got damage here. Okay, yeah, I believe you. Because it'll show more than the plain x-ray. You know, the x-ray may look, yeah, it looks okay, but then I get an MRI of the knee and he's got a torn meniscus and I can go, yeah, you've got some disease there. You're not old enough to get a knee joint replacement. Surgery might help, but you're still probably gonna have pain. So let's rehab that knee. Look at some other modalities. You might not be able to run on it, but you know, some weight loss, some physical therapy, a good quality knee brace, some beef up your analgesic medication a little bit. There's a lot of things you can do for these types of pains. So this is the big question. How did we get here? Well, you know, we've heard a lot of things this week and today. There's a lot of things. You know, pain being the fifth vital sign. You can't leave the doctor's office without something for pain. I know I've got PT coming up, but that's 3 weeks away. And what am I going to do between now and then? I'm going on a cruise next week, and I don't want to be in pain while I'm on the cruise. Yeah. You know, doc, you got to do something. Yeah, I'll give you some. I'll give you some. Something. Okay. All right. You know, and really, so much of what we do, there was a study in 1993 that in the New England Journal about chronic pain management in cancer patients. And yes, opioids were then and still are important pain management modalities for cancer pain, but that got extrapolated, and one of the conclusions was that long-term use of opioids was not harmful in cancer patients. And maybe they built up to it. They're not going to abuse it. They want to live. Okay. So in that study, it worked pretty well. Well, a lot of other people got on this, and the pharmaceutical company and so forth, that, okay, well, we can treat other pain in the same way. Chronic pain with opioids and no harmful effects. This was a study in a Danish study, I think, that in looking at a retrospective study that where they do a lot of things like questionnaires. How is your pain being managed now? And we know that many patients that are on opioids for a long period of time report, well, maybe, you know, my pain is not really a whole lot better now. So they have chronic pain, and an opioid is probably not the best drug for them. Now, they do work for many people, okay, and that's why they take them, okay. But they tend to lose their effectiveness over time, and then there's these potential harms: overdosing, tolerance, addiction, and then especially, I've got some interesting patients that I'm following right now who I know they have obstructive sleep apnea. They're overweight, and they're on a lot of opioids, and they're developing all kind of weird stuff like severe lower extremity edema and stasis dermatitis, and I think they've got cor pulmonale, and they've got so much respiratory depression from their opioid that they're getting a lot of other physiologic manifestations of that. So it's very hard to tease that out. It's hard to convince the patient that that's one of their problems, that they're getting respiratory depression from their opioid. So I'm just going to kind of go through this quickly with opioid use disorder, because again, I think there's a plenary tomorrow morning on this. So thinking about treatment options for opioid addiction, supervised detox, either inpatient or outpatient, and then long-term opioid outpatient treatment. Now, again, there's a little bit of shift here because we're kind of not just talking about pain, but we're talking about opioid use disorder. And again, there's a fine line, I think, between that dependence on pain and then addiction or opioid use disorder. And I would say as a clinician, I really think I have a lot more patients that have sort of a variation of that. They get 120 pills a month of hydrocodone, but then after 3 weeks, they're all gone. Okay? Well, they're either using them up or somebody's stealing them or they're diverting them somewhere. So that's really an opioid use disorder. So 3 main drugs, methadone, buprenorphine, and naltrexone. The studies for MAT, medication-assisted therapy, shows that patients that are getting these medications stay in treatment, they stay in a recovery longer, and they're less likely to use illegal drugs or overdose if they stick to a program. So the 3 treatments we mentioned, opioid agonist is the methadone, and the buprenorphine antagonist is the naltrexone, and then managing withdrawal. I won't go through all of these, but again, in acute opioid withdrawal, you have a activation of the sympathetic nervous system, so there's the eyes dilate, you can get nausea, cramps in the stomach, anxiety, irritability. And we actually use opioids. If somebody goes into a treatment program, they may be treated with an opioid, such as methadone or buprenorphine, if they're severe. No one. We say that no one dies from an opioid withdrawal. You could potentially trigger one, but the risk of an opioid withdrawal outside of a treatment program is that the person in withdrawal gets something and they take too much, and then they go from withdrawing to overdosing. So the agonist, we mentioned that the methadone is the agonist. Buprenorphine, I'm going to show you a slide in a minute why it's a safer drug, and then the antagonist, which is naltrexone. This is just some research data on the effectiveness of methadone for MAT, and it was shown that methadone was superior than placebo. We talked a little bit about methadone being a synthetic opioid. I won't go into that anymore. Again, MAT needs to be done in the context of other support, such as a counselor, social worker, a psychologist, and you have to do physicians have to do a training, which is minimum of 8 hours, in order to get a certification to prescribe buprenorphine and Suboxone. Kind of nothing else. So again, methadone. We talked a little bit about the risk of overdose. This is sort of like a dose curve here, and you get pain relief at the lower doses, and euphoria here. We don't really think about methadone as being much of a euphoric, but if you take enough of it, it can. And then if you get really high doses up here with coma and death, and once again you mix methadone or any opioid with alcohol or a benzo, you reach that saturation point of respiratory depression. That lowers that threshold for respiratory depression. And again, a similar study looking at buprenorphine as being better than placebo for keeping patients in a treatment. And these are people that are really wanting to get well. They're admitting they have an addiction problem, and they're willing to take an opioid either for pain treatment or for just opioid addiction. Now, what's different about buprenorphine with naloxone in the mixture is that there's a saturation point, and somewhere, this is a relative amount, but since there's an antagonist in the mixture, it reduces that risk of respiratory depression. And that just shows that you have to take it under the tongue. I think I'll just kind of move a little fast through some of the addiction treatment, because you're going to hear more about that, I think, tomorrow.